Hello everybody and welcome to our webinar tonight, Gross Motor Skills for Children Under 2 years. Before I go any further, I'd just like to acknowledge the traditional custodians of the land that we're meeting on tonight and pay respect to elders past, present and emerging. Our presenter tonight is Jessica Langham. Jessica is a physiotherapist who sees children and she practices in Armidale, Bellingen and Dorrigo. There will be a survey, an evaluation that will pop up at the end of tonight's webinar, and we would really love it if you could fill it in for us. A copy of this presentation and a recording of the webinar will be available on our website, and you'll get the website address in the follow-up email along with a certificate of attendance tomorrow. All right, I think that's all you need to hear from me at the moment. I'll hand over to Jess. Thank you.
Thank you, Jenny. Good evening, everybody. My name's Jessica Langham and I'm a physiotherapist who works with children, so those 0 to 18 years in Armidale, Dorrigo and Bellingen. And tonight I'm going to be presenting on gross motor skills for children under 2 years of age and what can physiotherapy do and when to refer. So tonight we're going to be reviewing gross motor skills for children 2 years and under. I'm going to help identify atypical gross motor development. We're going to try and help you understand physiotherapy involvement and identify when to refer a child to physiotherapy. We're going to have a look at a case study, and if there's some time remaining, answer any questions that you may have. So gross motor development is the development of gross motor skills with the goal of an independent child doing everyday activities. Gross motor development begins from birth, and there is significant gross motor developments that occur in the first 2 years of life. Gross motor skills are important for everyday function, and something I would like you all to remember is gross motor skills develop in a range of normal. So for example, the average age for a child to walk in Australia is 14 months. Some children may walk at 10 months and some children may walk at 17 months, but this is all within the range of normal. So this is a table I put in because I really liked how it showed how things develop over the first 2 years of life. So from birth to 4 months, primitive reflexes are quite present. They are still present and they do taper off over time. In the 4 months to 1 year time frame, they're improving their muscle tone, reducing their flexor tone and increasing their extensor tone. They're improving their balance and coordination, and movement becomes differentiated and functional. From their first to second year of life, they're improving their power and stability, better differentiated and more precise movements occur as well. And this is from the Mary Sheridan's From Birth to 5 Years Child's Developmental Progress book, and it's an excellent resource and I will be referring to it throughout the night. So at 1 month, the gross motor skills we expect to see are primitive reflexes. Arms and legs still have jerky movements. When they're on their tummy, so in prone, their head is turned to the side with their arms and legs flexed. When they're on their back, their head is to the side. When we pull to sit, so this is when we grab a child's hands and we pull them up from supine up to sitting, their head lags, so their head is left behind. But once they're up in sitting, they're able to hold their head vertical before it tips forward. Ventral suspension, which is when we're holding a baby on their tummy in the air, a 1 month old is able to hold their head in midline. So these pictures from the book that I mentioned just before demonstrates these positions. So this is the head lag we spoke about, ventral suspension, where they hold their head in sitting. This is an attempt to lift their head in prone, but as I said, when they are in prone, they usually have their knees tucked up, arms tucked underneath and their head turned to the side. So at 3 months, the gross motor skills we expect to see is in supine, their head in the midline and they're bringing their hands to midline. When we pull to sit, so again, grabbing their hands and pulling them up, there's little to no head lag. They're able to bring their head with the body. In supported sitting, they have their C-spine posturings, which you will see in the pictures to come, with a steady head. So they're not boppling around when they're up, they're able to hold their head nice and still. In ventral suspension, again, when Bub's on their tummy in the air, their head is held above the line of the body with their shoulders, hips and knees in extension. And when they're on their tummy, in prone, their head and shoulders are held off the ground with the use of their forearm support. So this bub here, as you can see, head's in midline, hands in midline. This hand was there before we could get the photo, but they moved away. This is the pull to sit, and as you can see, this bub's head is in line with the body, not quite chin tucked as much as you will see in further images, but pulling up beautifully. Elbows are flexed, hips are flexed and pulling up into sitting. This is the supported sitting, and as you can see, this is the C-spine shaped posture that I was talking about. I've put these two pictures in. This one might be about 2 months and this one's at 3 months of the same little boy. As you can see, the arm, the head and the shoulder height that they're able to lift increases as they get older. So at 6 months, the gross motor skills we expect to see are in supine. They're able to lift their head up and their arms move forward when it looks like you're going to lift them off the ground. When we pull to sit, so again, grabbing their hands and pulling them up, there's no head lag. They're able to tuck their chin and they actually flex and use their abdominals and pull themselves up into sitting. In sitting, they're able to sit independently with support and turn their head from side to side and look around without tumbling. Rolling, they're able to roll from their belly to their back first, and then afterwards they usually develop back to their belly, but that usually takes a little bit of time, so that can be between 6 and 7 months. But in saying that, any of these gross motor skills, as I said before, can develop early and they can develop a little bit later, but this is what we expect to see. In prone, their head and chest are lifted off the ground with the use of their hands and they're pushing out. You'll notice their elbows are in extension. So this first video here is a video of a baby rolling over from their belly to their back. And as I said, this is normally developed first. And then this bub is going to roll from their back to their belly. And then in this picture here, what we see is this bub is taking their hands to their feet and acknowledging their feet, kicking and moving symmetrically, beautifully, and then rolling onto their tummy. I put that one in because it is important children do play with their feet and bring their feet up to their body. In this picture here, you can see this bub's pushing out, elbows nice and straight and using their hands to push up into extension. You'll also notice that rocking posture. That's what children start to do when they bring their knees up and they look like they're going to crawl. And this pull to sit, you can see here, bubs got their chin tucked, abdominals are on, hips are nice and flexed, and you can see elbows are bent and they're pulling themselves up into sitting. At 9 months, the gross motor skills we expect to see. Sitting independently, they can pull into and out of sitting, reach for toys, and they're able to move a lot more than what they could before. There should be signs of crawling, so commando crawling, pivoting, coming onto hands and knees, rocking forwards and backwards like that last little boy was doing. And some children are able to stand. They're able to pull to stand, but they can't lower themselves back down. And this will be demonstrated in the videos following. So this bubba, as you can see, is exploring the floor, moving around, bringing their knees into flexion, kicking, lovely, going into a bit of a swimming posture. I think the TV is on in the background. You can see the flashing lights and they're pivoting around, beautiful, up onto hands and knees. Quite content watching the TV now, I believe. And this is the same bub a little bit later on. You can see reciprocal hand and knee crawling will come up, down for a rest. Up we go, lovely crawling, hands under shoulders, hips under knees, moving forward. So this video here is to demonstrate sitting and how a child's able to move into and out of sitting. And in this video here, we're watching how a bub around this age is able to pull to stand. So up into a high kneeling. Excellent, coming up into standing. You can see hips and knees and shoulders aren't in line. The backside's sticking out a little bit. Moving around, and that's the way they get down. They just plonk themselves down. Some hit straight down onto the backside, some are like a tree and they fall solidly, but that's how they get back down once they learn to pull to stand. At 12 months, we expect a child to be crawling on their hands and knees or in bear walk position. We expect them to be able to pull to stand and to sit back down. And they are starting to cruise furniture and walking with hands held. And as I said before, some children can be walking within this time frame. So this is reciprocal crawling, opposite hand, opposite knee, beautiful. This is the bear walk that I was talking about, up onto the hands and feet. And this is cruising. So this is where children use furniture or any surface that's that perfect height to walk around. And they walk sideways, so they step and this foot will come in and then Bub will step across and then the foot will come in, and that's how they get around. And this is a beautiful picture of Mum and Bub holding hands, walking along. So by 15 months, the gross motor skills we expect to see is they may be independent walking. And as I said before, 14 months is the average age for children in Australia to be walking. So we expect we could see it within this time frame. They should be able to stand independently or stand holding onto something. And again, kneeling, they should be able to kneel independently or with some form of support. And as you can see, this Bub here is kneeling beautifully with a bit of support, where this Bub is kneeling independently. Now, these two videos I've included for some walking purposes. So this is a video of a baby early walking. So as you can see, there's a wide base of support, arms are in extension and up. Doing some lovely quick stepping. There's short stepping, that base of support stays nice and wide. And then this is Bub after a period of time of walking, I think maybe a month or two. And as you can see, hands are still up, but they're not as high. Base of support is still wide, but narrower than what it was before. By 18 months, the gross motor skills we expect to see is independent walking and being able to carry objects. They should be able to run, but it's a cautious run. They have trouble negotiating obstacles, changing speed and direction. They should be able to sit by backing into a chair, so they'll stand up and walk backwards and sit down. They should be able to walk upstairs with their hands held. Kneeling, they should be able to kneel completely independently. And squatting, they should do a deep squat position. So significant hip flexion and knee flexion to pick up toys, and then use their hands to push off the ground or whatever's close to get back up. So in this video, you can see this Bub running. So quick, short steps, and then coming to a corner and slowing down. In this picture, you can see this little girl has backed in to sit down into the chair. In this video, you can see the little girl walking around carrying an object. And this is a picture of a little boy doing the deep squat. So quite significant hip flexion and knee flexion, but his backside is not on the floor. And then what he'll do is put his hand on the floor and push himself up into standing. By 2 years of age, a child should be able to stop, start, run, change their direction. Doesn't matter if they're running on grass or cement, it should be quite easy for them. They should be able to jump, climb up onto furniture. They should be able to go up and down stairs holding on, usually with 2 feet per each step. They should be able to throw forwards when they throw something. And when they're kicking, they should walk into the ball. So it's like they're walking still when they kick. They, again, are doing that beautiful deep squat that we spoke about before, but they're able to stand up without using their hands. So this is an example of a forward throw. This is an example of the jump, along with some forward throwing, but my videoing was terrible, so I'm sorry we missed that. This is an example of kicking, and what I'd like to say is this little boy is closer to 2 when we take this video, so he actually steps forward and kicks in the way I described, but he actually stops next to the ball. Usually, if they're a bit younger, I'd expect them to keep walking through. This is an example of that deep squat. So again, that nice hip and knee flexion, has a hold of a toy, then able to stand up without the use of the hands. And this is an example of the running for this age bracket. So running like there's no care in the world. So how do we identify atypical gross motor development? So the way that I see it developing to identify atypical gross motor development is when a child is not developing along the path as per usual. So for example, they're going through their gross motor skills, which I always see as a sequence of moving along to that independent child. So kind of like counting to 10. If they get along to 5, so a particular skill like sitting, and they just can't get past that sitting, they can't sit independently, they can't move in and out of sitting, that is a way of identifying atypical gross motor development. If they have any delays in gross motor skills for their age or parental and caregiver concern. And just a tip, I find the more you know about typical development for gross motor skills, the easier it is to identify atypical gross motor development and have a checklist for each age. This is something that I have. I have a checklist. So when I'm checking in with a child and I know that they're coming to see me and they're, say, for example, 6 weeks old, there's a couple of questions that I will ask. Like, for example, I'll ask mum how they're going with tummy time. There's a couple of postures that I'll look at, for example, when they're on the floor, and things that I want to check. And I'll also check, things like plagiocephaly, torticollis. And if I notice that for example, if you're a referrer to a physiotherapist, if you notice that something on that checklist that isn't ticked or is ticked, depending on how you work it, then that will help you understand when you should refer on. And also having resources. As a physiotherapist, we have significant amount of objective measures for each age for gross motor skills, and that really does help us quite a lot in identifying atypical gross motor development. So these are some links that I think are fantastic, and hopefully, fingers crossed, this works so I can show everyone what I'm talking about. So these links on pathways.org, it demonstrates the difference between typical and atypical. So, excuse me, I'll mute. Oh, yes, it's on mute. Fantastic. So this is a perfect video if you've got a 2-month-old, someone coming in that you're not sure about. These videos are fantastic because it compares typical to atypical. This video gives written examples of what we're looking at and what's typical and what's atypical, what we should be concerned about. So for example, how bub has their head in midline, where this bub's head's over to the side, that strong ATNR's there. What I'm going to do is I'm going to skip through and just show you some different things that I would like to watch with you tonight, if that's okay with you. So this is visual tracking. Again, this bub's not engaging in visual tracking, where this bub is. And if you see this, then you know, okay, bub's tracking typically. Okay, no, this is something I should be concerned about. Helps give you a little bit of guidance. So this is transition and what we expect to see with the body. Again, giving beautiful descriptions about what we're looking at, what we're concerned about. What looking for, here we go, is prone. So for 2 months, pushing on the forearms, head lifted up, beautiful extensor involvement, knees and hips are out behind, they're not tucked under, where this position's that typical position I would expect for a 1-month-old. Head to one side, knees, hips, elbows, all flexed underneath the body. Oops, sorry, gone a little bit too far there. So this is the pull to sit, as I was talking about. So how Bub's head's left behind, but gets to the top and is able to hold it beautifully. Bub's head's left behind, that's typical. But when we get to the top, Bub's head flips forward, and that's not what we expect. As you can see, curling into that C-spine sitting position. So I'll just let that play again so you can watch both. Alrighty, and then this is the sitting posture we were talking about. See, heads up, Bub's looking forward. Looks like Bub's actually a little bit upset, the poor little darling, but not requiring a significant amount of support, where this Bub is just needs support. Head's bopping all over the place, coming into that forward flex position. And then this is the ventral support position. So as they come down, you can see Bub's able to hold head up. Not happy camper about that, which I can understand, where these Bubs in a C-spine, unable to lift their head up in the line of the body, really enjoying that flexor position, not really wanting to come into that extension position. And then finally, we've got standing. So this Bub taking weight through, we're expecting them to bend down in the knees, but everything's in line, where this Bub's just wanting to flop forward. Alrighty, so I'm just going to show you the other two videos just so you can see what the changes are like we've spoken about just before. Hopefully. There we go. So again, now this is a 4-month-old, and we're just seeing what we expect. So again, typical and atypical. So we're on our back, reaching for a toy, bringing our hands and feet up like I showed in the video before, tracking the toy. This Bub's not in midline, not straight, is like curving to one side, head's tilted to one side, doesn't seem to be noticing the toy that's being held. And then we'll get to some prone time. So on the tummy, pushing through the forearms, head's lifted up, legs are out straight. Bub's doing okay, but wanting to bring knees up into flexion, having a little bit of trouble lifting their head up. So I think Bub will reach forward for an object. I might have missed that, I'm sorry, before when I was over here looking at Bub. But you can see they're beautiful examples of what's typical and atypical for 4-month-old. I'll just show you the pull to sit. So this is what I was talking about. So Bub's lifting head, bending elbows, coming up beautifully, where this Bub's head's left behind, still in that C-spine, head's flopping forward. Not able to lift up to look at this person when they come up. Ooh. See, where this Bub's able to lift up and look at the person. So in that sitting posture, so the Bub's head's bobbling all over the place in this one, where this one, Bub's head's got beautiful control as they're reaching forward. And this is ventral suspension. Oh, sorry. So you can see head being lifted up, legs, knees straight into extension, where Bub's still wanting to curl up in that flex posture. And I'm just looking for standing. Here we go. And then this is standing. So as you can see, taking some weight, everything's in midline, hips are just behind shoulders, where Bub's struggling to lift head up. Oh, we're up, but flopping forward. Finally, the last video. So this is 6 months. So if you're ever concerned or want to learn more, I highly recommend watching these videos. They're so great just to give you a bit of an idea. Look, it may not answer exactly what you're talking about or what you're seeing, but it might give you a bit of guidance. So as I said before, 6 months, same setup. We're going to have typical and atypical. So what we'll see is, so reaching for that toy, bringing the toy down to the mouth, legs coming up into a flex position, grabbing it with everything we've got, having a bit of a chew on the toy, kicking the legs, nice and coordinated movement. Where in this one, Bub seems to be looking at the toy and engaging, but there's no real movement, you know, of bringing the hands to midline or legs up to midline to get a hold of the toy. So this is an example of rolling and how we can encourage rolling. Works quite well, shaking the toy. Example of beautiful rolling over from back to belly from this bub. Pushing through their hands lovely through extension, where this bub's just struggling to roll over. Watching the toy, but finding it really hard to bring everything across to midline to roll over. And then this is tummy time. So you can see beautiful extension in the elbows, weight going through the hands, moving the knees, pivoting, all those things that I showed you on the video. Where in this bub, just not happening. Trying to flex and use their legs to move around, but just unable to quite get there. So if you were to see something atypical like this, I would expect a referral for a pediatrician and also for a physiotherapist, just to see if they can help get them moving and get them going. So I was just going to show you the pull to sit again. So as you can see, bubs pulling themselves up, abdominals, elbows bent, pulling up beautifully. Where in this video, elbows are straight, head still lagging and left behind, struggling to sit up, but holding themselves a bit better when they're up. They're not flopping forward like they did before. But as you can see, that C-spine posture, where in this one, when bub comes up, they've got a bit straighter, a little bit of a C-spine down the lumbar spine, which is normal, but sitting up beautifully and straight. And then in sitting, struggling to hold head in midline, wanting to tilt off to the side, where bub's doing very well, independent sitting at 6 months. As I said, some children will be sitting supported at this age, but independently with supported sitting. Reaching forward, lovely for the toys, legs are out straight. Just a tip, if you are teaching a child to sit, a wider base of support makes it easier, and when they get better, you can bring their legs in a bit narrower. But as you can see, having trouble, no hands from the therapist here, where the therapist was providing a significant amount of support here. And as I said, it is expected to see supported independent sitting, but not where we have to completely support the child. Ventral suspension, so everything out straight, head above midline, beautiful. This is great to see. It's an improvement to the last videos, but bub should be able to lift their head up just a little bit higher. And again, in standing. So wanting to drop, this bub's wanting to drop down to flexion, struggling to hold head up, where this bub's all beautiful, standing up, turning their head, looking around, and doing a fantastic job. So as I said before, these are great videos, something I definitely recommend looking at, just to try and help familiarise yourself with typical and atypical for these ages. So this is the website. This is the homepage. It's an excellent website that's out there. There is so many resources and so much information on there. Have a look. It's a little bit overwhelming, but it's a great resource, and there's those videos that I really highly recommend. So this book, Mary Sheridan's From Birth to 5 Years, is a great resource, and I really, really like it. Don't mind me. I'm just flipping over the first few pages. I've just got it sitting right here. And the reason why I like it, it's talking about children's development progression over from birth to 5 years, but not only gross motor, it's also talking about fine motor, perceptual, and non-verbal, cognitive development, speech, language, communication, social behaviour and play, early literacy development, self-regulation of emotions and attention, attachment, temperament, and the development of self, vision and hearing. And it does the same as what I've done before. It breaks it up into each age group and what we expect to see. It also provides key points. So this is age 1 month. So it's got, I hope you can see that, it's got key points that we really look out for each stage. And then it has some beautiful pictures like the one I put into the PowerPoint. So definitely something I would recommend getting if this is something you're interested in. It's a really good resource. This is also something I really like. It's a red flags early identification guide for children aged birth to 5 years. There is a top to that, but I think I've somehow got rid of it, sorry. It's done by Queensland Health and it's fantastic. As you can see, it has what red flags are at particular ages and social, emotional, communication, cognition, fine motor and self-care, and gross motor. And if they're not doing particular things, like for example, not rolling at 9 months, that's a red flag. You need to refer to a pediatrician, and it's a great resource. It's just like that checklist I was speaking of before. Just quickly something you can look at, oh, okay, yep, that is a problem for that age. Let's refer them on. So how can physiotherapy be involved? So physiotherapy can assist in gross motor development. We can do that because we're trained in how to modify tasks. We can help break down tasks to learn parts of a skill, and we can help children keep progressing along that pathway of gross motor development. We're able to make skills that seem very hard and complex quite easy, and we're able to watch to pick up exactly what part of it they're finding hard, what muscles are involved, what movements are involved, and what we can do to make it easier for them. We're also able to educate parents and families on how to best support their child to achieve a gross motor skill, and we have age-appropriate assessments for gross motor skills. So there's the NSMDA, which is a neurological sensory motor development assessment, and that it has assessments for children from 1 month to 6 years. There is the AIM, so the Albert Infant Motor Scale, which is for 0 to 18 months of age. And that has a beautiful pictures. I don't know if I've got it. Oh yeah, there's part here. I'll just fold it. And it has some, I'm hoping you can see this, but it has pictures and it shows you how they progress along and what to look for and what's coming next. So I really like that one. It also has a percentile where you can rank a child and see what percentile they're sitting on for their gross motor skills. And there's the NSMDA, which is the HIND, which is the Hammersmith Infant Neurological Examination, which is for 3 to 24 months. So in these early years, we have gross motor assessments to identify where children are tracking. Some of them are not they're not diagnostic, but they're able to identify if a child is above average, average, below average, and then we can reassess them to see if they're improving, if they're not. And it's a great way to track gross motor development. And it also is a great way of putting parents' minds at ease. So for example, you have an anxious mum feeling like their child's not developing age appropriately, we can do an assessment to identify whether they are or they are not. And parents relax more when you've got an objective assessment to say, you know, they're actually doing really well. Sorry. So when to refer? As a physiotherapist, we believe that you should refer sooner rather than later. about anything that I'm about to talk about. So if you are unsure about gross motor development, and if a child is progressing well with their gross motor skills, you can refer them to a physiotherapist that works with children, and they are able to do one of those objective measures to identify how the child is going. If there is a gross motor delay present, if they're a high risk infant, so if they have low birth weight, if they're a prem bub, or they have fetal alcohol syndrome, if they have low or high tone, bubs and children that have low tone require a lot more exercise, a lot more strength, a lot more stability to be able to achieve gross motor skills. It's a lot harder for them. Any children with disabilities, we're here to help them with their gross motor development and keep them tracking along. And if a child's clumsy, clumsy children are often clumsy for a reason. There's something underlying and behind that reason. So, referring on then would be great. And if they're avoiding a task, children are so clever, and they're clever from a young age. If, for example, tummy time, if a bub screams when you put them on their tummy because they know you're going to take them out of it because it's hard work, they're going to avoid it, and they're just going to keep screaming every time you put them down. And we're able to modify tasks to make it easier. And if they've got orthopedic issues like plagiocephaly, torticollis, DDH, and TEV, and usually, often when children have an orthopedic issue, gross motor delay can also be present as well. So why an early referral? So my case study that I'm going to speak about later, I got an early referral. I got him on the NDIS, and the NDIS identified children with gross motor delay as able to access NDIS, which is amazing, because the NDIS then opens up a whole nother world. These children are able to access much more therapy, because going to physiotherapy can be expensive, but the NDIS are able to fund that. Children are able to get supports they need to help them develop their skills, whether they're shoes or equipment. And it just really opens up the world, especially for those of low socioeconomic status. They're able to access a lot more physio, and that stress of trying to afford it is gone. An early referral helps make gross motor development easier for us as a therapist working with the child. So if, for example, you refer them early when they're, struggling with sitting, from that, we're able to work through that problem and help them move along their pathway, where if we don't, those subsequent issues can occur. And through reducing those subsequent issues helps reduce anxiety and stress for the family. Sometimes parents come in and they see you and they're like, oh, look, my child's not doing this, and I've been told to wait a month and see if they improve. But in that month, aren't given any tools or anything to try and help bub master a gross motor skill. So through just referring them to a physio, we're able to give them a couple of tips and tricks to make that task easier. Then they're doing it, and it's a lot more relaxed for everyone involved. So this is my case study. This is Mr. T. So Mr. T was referred to me at 18 months old. He was a knee walker. He was delayed in all his gross motor skills and did not like his feet touching the ground. He was referred to me because at 18 months, he still was unable to pull to stand. So after 1 month of therapy, we were able to achieve pull to stand. If you can see here, he's leaning up against the bed because he required trunk support still. He would sway from side to side and was very unbalanced when he was in this position. After 2 months of therapy, he was able to stand with one arm supported, and he was starting to cruise. After 3 months of therapy, he started pushing a walker, which was fantastic, but he had limited foot clearance in swing phase. So as you can see, there's no real swing phase happening here. So the thing I find hard is if children are referred to us when they are older. So for example, this boy was 18 months. He's quite tall for his age, and trying to find a walker that was the right height that is encouraging for him to stand to push was quite difficult. This one actually was the best height for him knee walking. It was easier for him to push it while knee walking. So if we can get these children just that little bit earlier, we're able to utilize things that are easily accessible. For example, this toy, I'm pretty sure, is able to be got from Kmart, on Buyswapswell, on Facebook. They're very accessible. But once they get that bit taller, it just makes it that bit harder. After 5 months of therapy, he started taking steps, but still knee walking everywhere, but little distances, he was starting to take steps. So I'll play that one again. It was a very exciting moment for me when I got this video. So it took 6 months of therapy to get him walking independently indoors. After 7 months of therapy, we got him walking independently outdoors, and I really apologize for this photo. The family sent me it, and you know how it is with technology, but that is him walking outside, and that's grass around everywhere, and he's carrying a stick. Now we're working on climbing. He's having a hard time trying to climb, but he's trying his hardest, and I actually got a video yesterday of him climbing up onto a little kid's table, which is scary for the parents, but exciting for me. The reason why I wanted to use him as a case study is it took me 7 months to get him walking around outside. He did have low tone, well, he does have low tone, and the parents reported that he had gross motor delay throughout. He had trouble breastfeeding, and there were other things, but he had been to have his checks, and he was gross motor delayed at all his checks. The parents weren't quite accepting that he was gross motor delay, so there wasn't parental concern there. It was from a concerned GP that he was referred to me. But if he was referred to me earlier when he was struggling to sit or roll, I don't believe, and I cannot guarantee, but I don't believe it would have took me 7 months of therapy to get him walking outside. Because as I said before, as children get older, they get smarter. They learn the word no, they know how to avoid tasks, and they learn to be stubborn and chuck tantrums. Don't get me wrong, when babies are younger, they're able to do all of these things as well. But as they get older, they're just harder to deal with and negotiate. So if we can get on these gross motor issues earlier, then it makes it easier in the long run. So in summary, gross motor skills have a range of normal. Knowing what typical is helps identify atypical, have a checklist and resources, and refer to them. Look, I can say in myself, I cannot remember everything. I can't remember everything I do in my job. That's why I have all these resources and textbooks and assessments to utilize, and utilize them. Just set something up really good for yourself that works for you. And even on that checklist, if they can't do X, Y, and Z, have a list of the physiotherapist and just that you can refer to, and let them, process be streamlined a little bit more. Physiotherapy can simplify tasks to help a child master their gross motor skills. Early referral means earlier skill development. And if you're unsure, refer on to a physiotherapist. So in my world where I work, I have a relationship with a few GPs and one community health nurse and a community physiotherapist. And if any of them are concerned, they will ring me or text me and tell me about the child that they're seeing. And with parents' permission, I've been sent videos and photos and saying, is this something you feel like you can work with? Are you happy that I refer them on, or do you think they're okay? And having that relationship makes it so much easier for everyone involved. So thank you, everyone. I hope you've enjoyed the presentation so far and you've got something out of it. These are my contact details. My business is Country Family Physiotherapy. I'm in Armidale, Dorrigo, Bellingen and surrounding areas. That's my contact number and that's my email. I'm more than happy to answer any questions or have a chat about anything if something pops up after the presentation tonight. And I was wondering if anyone has any questions or anything they would like to discuss.
So we do have one question that's come through.
Yeah.
Are the questions in the blue book for 4, 6, 12 and 18 months adequate for a basic assessment?
Oh, you'll have to refresh my brain what's in those. I should have went and grabbed my sons out of the car. I think they are, but I think if you knew a little bit more about it, you could observe the child as well. So, for example, like if you had a checklist and there were particular things you were looking for, like what I had in the start of the presentation, if you could have those written down as well, like things to look out for. So, for example, that atypical and typical baby that was 4 months old or even 2 months old wanting to come into that flex position, if you had written down that at that age on their tummy you expect to see them look like blah, then that way you know what you're looking out for. Does that make sense? So they're there
Yes,
for a
I
reason,
think
and they
so.
do help, but I think as therapists, we need to know more.
Okay. Is bottom shuffling counted as atypical, or does it sort of fit somewhere on the milestone pathway?
So this is controversial a little bit because every therapist has their own opinion. Okay. My opinion is I would try and get that child out of bottom shuffling and try and teach them reciprocal crawling because it's mind body connections. Some therapists say bottom shuffling is fine. Personally, I don't like it. I prefer to get kids crawling. In this book, they talk about bottom shuffling, and they say that it's a part of the pathway and that these children usually are gross motor delayed and take longer to walk.
Just wondering about babies who are pigeon-toed with assisted walking. Is that something they normally grow out of as they start walking more independently, or is that something that would warrant a referral?
I personally would refer. Typically, children with in-towing, it's a part of normal development and they do come straight and grow out, but you want to ensure that it's not their hips, it's not that's causing the issue, and it's not tibial torsion or metatarsus adductus. So hopefully, I don't know how much everyone understands. So metatarsus adductus is where our toes kind of turn in and make that arc banana position with our foot. Tibial torsion is twisting of the tibia and to hips to make sure things aren't dislocating or causing issues there.
Okay. Can low tone in kids be intervened beyond preschool age?
Yes, yes, definitely. So you're asking me if a 7-year-old had low tone, should they see physio? I'm guessing. Um, so yeah, a low tone is lifelong and you want to help them develop because as we know, we grow, our bones get longer and we want our muscles to be as strong as possible around the joint to give them as much stability as possible. So definitely intervene until they're stable and strong and you're happy with how they're going. Also shoes, sorry, I'm going off in a tangent, but if they are like 7 or 8 or 9 and they're quite low toned, really important to get them in good footwear to support their joints.
How long should we accept toe walking? Any particular age?
Yeah, okay. So toe walking's okay intermittently as they start, but I like them being flat-footed. So for example, they go on their toe, like they're just starting to walk and they're going up and down. But honestly, it's textbook, I think it's 3. If they're still toe walking after 3, we're concerned. But personally, I like them down. I want to get them down as soon as possible, get them into the right footwear to keep them down so they're not toe walking.
How do I get the red flag chart that you showed us? Because it would be a great quick reference.
Google exactly what it said in the title. So if you Google red flag gross motor, I'll just go back to that actually, be quicker. So if you write down this heading here, that's exactly what it's called. And it'll come up with more writing at the top. And I'll leave that there. So hopefully you can see it. Write it up.
And we will have a copy of the slides on our website next to a recording of the webinar. So you'll be able to go through and have a look. Oh, we have another question, I think, which is just great. Do you encourage footwear such as Pedro boots, even for home use for toe walking, or just for outdoor use?
Yeah, I encourage Pedro boots, but I also encourage First Walkers. Don't know if you've heard of them. Google them. They're in Melbourne, Australia. Love those shoes too. And I do encourage them. If a child is toe walking, I want a boot that takes away that ability and a nice hard sole so they can't get up onto their tippy toes. But it depends on the age of the child, how old that child is that's toe walking, because the First Walkers only go up to juniors. And of course the Pedros.
Okay, if there's any more questions to come through, don't forget to do the evaluation. I just wanted to let you know that we are doing a COVID vaccine update for general practice on Friday at 1 p.m. It's just a quick update to try and answer the many, many questions that we have coming through. Thanks, Jess. That was really interesting, and it's nice to be doing a different topic
No
than the
worries. I hope
usual.
everyone enjoyed it and got something out of it.
Thanks, everybody, and we'll catch you all at the next webinar.
Have a good night. Thanks, guys.